So what's the goal of our program, of our sort of whole team? And by the way, this is your federal tax dollars at work. This is a completely CDC-funded program. Started about 10 years ago, and I really became involved about 5 or 6 years ago, and the program has really grown dramatically in that period of time, here and in every state. But I think Nebraskans should be very proud of how we've grown this program and how CDC has supported us because of the fact that we as a team, we'll brag, have done a really, we think, good job in creating a model for a successful HAI-AR team. But our goal is to monitor and reduce healthcare-associated infections at all levels of healthcare, to support stewardship, and we'll talk specifically about that in a little bit, to detect outbreaks or resistance, particularly single types of multi-drug resistance, to manage and contain any outbreaks or resistance, to provide education for healthcare professionals and healthcare workers, and also for the public, to do things like when Dr. Penn sort of raises the issue about, I definitely see a shift and a trend in the public in terms of the understanding of the side effects of antibiotics, concerns about C. diff, concerns about the microbiome, just in the past few years. So a lot of that public education and then the resources for healthcare workers can be found on the HAI website. So all you have to do is, if you Google DHHS HAI, you'll actually you'll find the Healthcare Associated Infections Antimicrobial Resistance website, and that has, as I said, information for the public and information for healthcare professionals, so you can actually choose which pages you want to go to. But there's also resources that you might want to direct your patients to. So the two most common questions we get called in from the public are, there's somebody at work or there's somebody at home with MRSA, or there's somebody at home or somebody at work with C. diff. How do I handle that? It's our two most common phone calls. So we actually have really nice educational information that actually helps people to guide them on how to handle things in the home or at work. So not only for yourself, but for your patients. So our support for stewardship in the state actually really gets to the highest levels. This is about 1.5 years ago when Governor Ricketts actually signed and proclaimed a particular week, Antibiotic Awareness Week, that usually occurs in November. We did that in 2017 and 2018. So in this picture, Dr. Tom Williams, who was the former Director of Public Health, is present. But our new CEO of DHHS, Danette Smith, our Acting Director of Public Health, Ashley Newmeyer, and Dr. Safranek are all extremely supportive of what we do. So one of the things that we try and do is help the stewardship programs know where to focus stewardship efforts. Because obviously we would really like to be able to get in there and support stewardship and be involved with every hospital, long-term care facility, outpatient facility in the state. Obviously, we can't do that for everyone, and so sometimes we have to try and direct our efforts to where stewardship might have the greatest impact. So if we see individual cases of extremely resistant organisms, we see outbreak settings. There's clusters of resistance that are detected either by our antibiogram or reported to us by a facility. We see higher CDI rates in either a region or a facility. Or we see areas where there's what we call hotspot antibiotic data. So Medicare data that we review comes back to us and says, okay, in this particular local health department jurisdiction, there's really higher antibiotic use than in the surrounding areas. So those are places where we'll help focus stewardship. So in order to do some of those things that I just mentioned, we have to detect those things. And one of the main ways we do that detection is by creating an antimicrobial susceptibility registry and an antibiogram. And in order to do that, you have to move back because things have to be reported to you before you can actually detect them. And so I have to, I don't know if Dr. Safranek was able to be here. We have a few emergencies going on, but back about a little less than 10 years ago, we started requesting that certain organisms be reportable via electronic lab reporting. It's now gone from about 20% of the hospital and outside laboratories to over 90% of the microbiology lab reports in the state now come to us via electronic lab reporting. But not every single culture comes to us. We have to decide what things are actually on the reportable disease list. And if I'm just going to move from some slides, we wanted to make sure that all the organisms that would produce highly multi-drug resistance via ESBLs, extended spectrum beta lactamases, or carbapenem resistance. So that's why we actually have all E. coli, all Klebsiella, all Enterobacter, all Pseudomonas, all Acinetobacter are actually reported into us because we want to be able to pick up the emergent resistant organisms that could be present in those species. In addition, we want to look for vancomycin resistance. We want to look for Candida auris. We have not had any in the state, and we're keeping our fingers crossed, but we want to be able to pick that up as soon as that happens. So we expanded the reportable disease list on January 1st, 2017 to include these organisms here so that we would actually be able to pick up resistance developing within those species. So some of those, there are certain things we want to know right away. We want to know carbapenem resistance right away. We want to know vancomycin resistance right away. So those are reportable within 24 hours to us, whether or not a lab reports into electronic lab reporting. Some other things, Acinetobacter, Citrobacter, those are reportable with 7 days and only from labs that report into ELR. And what happens as a result of that, I'm just going to move up and then move back a little bit, is all that information comes in, and it is much more complicated. When I first started this job, I'm not the tech-savvy soul part of the program, as everybody who works with me knows. But it's amazing what it takes for this information to come from labs to then be coded and filtered and maintained so that it comes out the other end as a line list with a susceptibility pattern. And Ishrat is actually the person who is doing that right now. Dr. Caitlin Padati, who many of you had met before, was doing it before, and we lost her to Iowa. Of all places, they had to steal her over to Iowa as the state epidemiologist. So we're now being able to pick back up and really maintain and sophisticate this registry. But if, for those of you who are into HLA7 messages, et cetera, or HL7 messages and PC1 data, PV1 data, that's some of the technological aspects to it. And Dr. Safranek was really the person who started that all. But the end result, as I said, is a line list. And this antibiogram gets downloaded nightly. And then we can look, and there should be, this is for an example from 2017, but we can actually pull up this antibiogram on a particular day, and for the last 365 days, it will tell us for the reportable gram-positives, and then for the reportable gram-negatives, for the antibiotics that we select to look for, what percentage are susceptible or resistant, depending on how you want to look at it, to a particular antibiotic. And this is crucial because from this antibiogram, you can then, and what has been done is to write code, and I'm certainly not the person who writes the code, but to develop for example, carbapenem resistance registry. So every day, Dr. Kamal Ahmed checks our CRE registry so that we can determine within 24 hours if we see an organism that's carbapenem resistant from anywhere around the state, any of these laboratories that report into ELR. It also helps, and this actually helped us in one particular scenario, is we are now working to develop regional antibiograms. Now, last year at this, we thought that by this time we would have regional antibiograms for every county or district in the state. It's turned out to be a lot more complicated, and then with the loss of Dr. Pradati for a while, but that's still our goal. But we have been able to pick up, for example, there was one scenario where we were concerned about quinolone overuse, and we looked at the resistance patterns in one particular area and found probably twice the level of resistance of E. coli to quinolones than in the rest of the state. And so it helps us to be able to, as I say, to focus and look at those areas of resistance. One other thing I just want to mention is that in addition, I'm not sure, we are also able, all Clostridium difficile positive reports are actually reportable in the state of Nebraska. That's actually a real tremendous wealth of data. Not many other states have that capacity. So this is actually a map that Joanna put together that looks at the rates in 2018 for CDI by county. And one of the particular ways we want to use that is we also have a nursing home database. So from all the same information that actually comes into our antibiogram and antimicrobial susceptibility, when the patient's address is that of a nursing home, we actually now have a nursing home database, so we can actually code an individual patient's home address to the fact that that's a nursing home residence. And so our goal over the next year is to actually use that information along with NHSN data to find out where there might be pockets of CDI, and that way we can work with stewardship and other prevention methods to try and decrease CDI rates in certain long-term care facilities. So I'm just going to move past our antibiogram here. And so as I mentioned before, the things that we're looking at carbapenem resistance, we're looking for the extended spectrum beta lactamases. There used to be in the days maybe when Dr. Rupp and I were sort of training, we didn't really have any CREs, but we did have ESBLs. And, but there were some nice, like ESBLs that were only really resistant to the first generation cephalosporins. Now the ESBLs are resistant to the third generation cephalosporins. And one of the reasons we're going to start to look at those a little bit more is because if you look at these third generation cephalosporins that will break down cefotaxime and ceftriaxone, and that's how you'll pick them up. So if you're looking at a lab report and you see something is resistant to ceftriaxone, that is usually a proxy or a marker for ESBLs. But when you start to look at those things, they the number of best drugs, of the best class of drugs to treat those are the carbapenems. So if you then treat them with a carbapenem and you've got somebody who's on and off antibiotics, prolonged hospitalization for a long period of time, what happens next is they can develop carbapenem resistance. And so, we also want to know when we have clusters of ESBLs, how can we focus stewardship? How can we focus containment so that those folks don't end up developing carbapenem resistance? So this is one of my favorite slides, and saying carbapenemase producing carbapenem-resistant Enterobacteriaceae is one of my favorite phrases. You can say that 5 times fast. But organisms, the Enterobacteriaceae, those gram-negative organisms that can live in the gut, entero meaning in gut or intestines, which is why they're referred that way, can develop resistance to the carbapenems either via other ESBLs, via an intrinsic mechanism for something called porins, or because of the presence of a carbapenemase. And carbapenemases are enzymes that actually will cleave or break down certain carbapenem antibiotics. So those are present on their mobile genetic elements on plasmids. So, and for those of you who had the scenario where you've worked with us because of a presence of a CPCRE, and it's one of the reasons CDC refers to this, and I don't know if Dr. Srinivasan is, I don't think he's right in the room right now, but CDC coined the nightmare bacteria. But the reason is because when something's on a plasmid, a mobile genetic element, it's a lot easier to move it from one organism to another, but also it can jump species. And usually when that happens, it's within a particular patient, but it can be theoretically from patient to patient. So the concern is if you have one organism that's highly resistant and has this carbapenemase, but then there's another organism in this patient who's been in the hospital for a long time that's even more resistant. And the plasmid, these organisms get friendly with each other, and the plasmid jumps from one to the other. You can then develop even greater resistance. So that's why if you have someone with the CPCRE in your facility, you get a phone call from us pretty darn quickly, and we help work with you on how to contain that. But I think this umbrella picture is really nice because you can have carbapenem resistance that's not due to carbapenemase or that is. Okay. These are the 5 different most common carbapenemases that are present. We never, use their full name if we're talking amongst ourselves or with you, but we talk about KPCs, NDMs, VIMs, that's my favorite one, OXO48 or IMPs. And what actually happens so there are 2 labs that are validated to actually perform testing for the presence of carbapenemase, and that's the UNMC Nebraska Medicine Laboratory and the Allegiant Core Lab. There are 2 other labs that are going to be are working to finish their validation. That's at Methodist and one other private laboratory. But sort of for everybody else, what will happen is the susceptibility pattern will come back. It will say that its organism is resistant to one or more of the carbapenems. And then what happens is that usually the lab, the lab technician, technologist will recognize that and send that off to NPHL or to Allegiant Core Lab to actually confirm that testing. Or sometimes Ishrat will pick that up, then we'll call the lab and say, hey guys, you got to send it to NPHL for testing. And there's 2 types of testing. That's what we call phenotypic testing or molecular testing. And the phenotypic testing just tells us there's a carbapenemase present. The molecular testing tells us which one it is. And that's important because knowing which particular kind of carbapenemase it is will help us follow whether or not there are outbreaks, and also if it's something that we've never seen before. And we'll talk a little about the types we see in Nebraska in a minute. But this is the slide, and this is this is what's giving me nightmares. Because in 2017, so we started measuring this January 1st of 2017. We had 45 CREs sent for confirmatory testing. 7 turned out to be carbapenemase producers. So about 1 out of 7. Same thing in 2018. This year so far, unfortunately, that bottom number is now 12. So we already have 12 carbapenemase producing CREs in the state of Nebraska in 2019. So at this rate, we will have tripled from last year to this year. So, which means that we haven't had a lot of days off. And this year we've been working hard to contain in facilities and try and increase our efforts to not only contain but prevent. And that is where stewardship is so crucial. So this just summarizes, the numbers on the prior slide in terms of how many isolates were resistant to carbapenemase from 2017 until 9. Most commonly found in terms of a clinical culture in the urine, but in a variety of settings. When we talk about CRE, people refer to the big 3. And the big 3 are E. coli, Klebsiella, and Enterobacter, but you can see them in a few other organisms like Serratia, Citrobacter, and Providentia. And the most common type of carbapenemase is KPC, or Klebsiella pneumoniae carbapenemase. than NDMs and those others. But it appears that in the Midwest, that there's actually more of the non-KPC, like if you're in New York City and someone has a carbapenem-resistant Klebsiella pneumoniae organism, 95% of those are due to KPC. Here, and in the whole Midwest, what we call Central Region, which is North, South Dakota, us, Kansas, Arkansas, Oklahoma, Minnesota, and Missouri, we tend to have still KPC is the most common, but a few more NDMs, VIMs, and IMPs, some of which may have an agricultural connection, although that's still being looked at more specifically. So now we've either detected, and the thing that we are focused on most specifically, but not completely, is picking up carbapenem-resistant organisms. We also, via our detection that we talked about, might pick up a cluster, might pick up an overall general trend towards resistance, and we'll direct stewardship that way. But let's say we have picked up a very highly resistant MDRO, so a CPCRE, for example. What's going to happen in that respect? How do we go about containing that? And there are two major guidelines that you can use to focus on that. One of them, and actually the CDC has just updated and just come out with a new guidance for control and containment of highly multi-drug resistant organisms. Just came out about a month to 2 months ago. That will be going up on our website, but it's actually on the CDC website. But it's an update to this facility guidance for control of CRE. It's a tremendous guideline, and we have a link to that on our website. And then we have created for Nebraska, a carbapenem-resistant Enterobacteriaceae response or investigation guideline. So if you actually go to our website and you go to Antimicrobial Resistance, there's a link to antimicrobial resistance information for healthcare providers. And then if you go to that page and you scroll down, you'll see a whole bunch of resources on the management, detection, management, and control of CREs. So I'm just going to walk through. These slides are really, so you don't have to take notes and you can see them, but I'm going to kind of walk you through what happens when one of the three of us gets a phone. So Margaret Ishrat or I will usually get that information and we'll call an individual facility and say, gosh, I don't know if you know this, but you've got somebody with a highly resistant organism in your facility. Here's what we need to do. We send the resources and we walk folks through this. But the number one most important thing is actually is containment. So if that individual who we are in the process of confirming, do they have carbapenemase producing CRE? Is that person in isolation in a private room? If they're not in a private room, let's put them in a private room. They need to be placed in contact precautions. And so that's the first thing we want to manage. We want to make sure that the isolate has gone, as I said, for confirmatory testing. And then we go through trying to find out where did this come from. Because if the person was just transferred 1 to 2 days before from a long-term care facility into acute care facility because they're ill, the folks who are actually back at the long-term care facility may be at risk. So what we want to try and determine is once we have containment in terms of this individual person, is who's at risk for having acquired colonization. Now, remember we talked about these are Enterobacteriaceae, which means they live in the gut. So even though someone may have a urinary tract infection or a wound infection or a pneumonia, the place where it started and where it's set up shop is actually in their gut. And so if other individuals around them have acquired colonization, it's actually going to be residing in their intestinal tract. And so based on experience, CDC recommendation, protocols actually set up, Nebraska Medicine was one of the first places to create, I think, one of the most aggressive screening processes for this, is we look at folks who were within 3 doors on either side for 3 days or more, any roommates, and anyone who had a procedure with a reusable device after the index patient. Those are the people at highest risk in general. Sometimes we'll find other situations where we consider people might be at risk, but that's our standard. It's sort of like a ring approach. These are the folks that are involved. Now, we've actually had situations where we had an unusual CPCRE or someone who, for example, was going back and forth and using the same whirlpool tub on a daily basis, and et cetera. And so then we might expand our testing to include everybody who'd actually used that same whirlpool therapy tub over a period of weeks. So sometimes what we're trying to do, so once we determine, okay, these are the folks that we see, 12 people, sometimes it's 50 people, who we think might be at risk for having acquired colonization, then we want to do what's called colonization testing or screening. So we're actually not doing a culture, because if you can do it, you have to do a rectal culture or a stool culture, it takes a really long time, there's tons, of bacteria there. What you actually do is a swab, a perirectal swab, and our protocols are so specific that we have pictures on our website of what's too much stool and what's too little stool on the swab, so it's very pictorial. Gives you an idea of what we're looking for and what the lab is actually going to find most useful. And then the CDC has created this really wonderful acute regional laboratory network. So before this year, NPHL, Nebraska Medicine, which many of you may know is a sort of combined laboratory, would actually do most of the colonization screening. Because of the unfortunate situation where we now have more and more people getting screened, we're utilizing this wonderful CDC resource, the ARLN, or Acute Regional Laboratory Network Lab. The ARLN for our region is in Minnesota. So if you're one of those facilities, and if anyone's here has done this, then we work on determining how many swabs. Did they overnight the special swabs? Folks in the facility, we work with the IP, actually do those swabs, and then they get sent back. And they do those results, because they're PCR, the same day. And so we determine, has any transmission occurred? If transmission hasn't occurred, right, we're all feeling a little more comfortable, and we go forward in trying to determine how do we continue containment. If transmission has occurred, then we're going to need to talk about, okay, now do we need to expand our screening? Now what else do we need to do? How do we think that transmission occurred? Because that will direct what further screening or further management we take. Okay. I am in the service of time. There are certain things I'm not going to go over, but a lot of this is information I've already talked about. It's also in our investigation guidance and our screening protocol. In our booth outside, we have copies of that, and we also have, as I said, they're also on our website. We're in the process of updating it a little bit, but they're really quite useful and can help guide you through this tough scenario. The one other thing I quickly want to mention is what happens if there's an outbreak. And so we actually consider, just in terms of the way we respond, one CPCRE as an outbreak in terms of the fact that we do an investigation. But what happens if we see more than that? Or if we see another organism? If we see a highly resistant organism in a unit, for example, and there are more than we expect to have? Our team also gets involved. And this is also where ICAR actually gets involved, because obviously the number one reason that things spread within hospitals, there can be reasons in terms of equipment, et cetera, but it's hand hygiene. And so ICAR will actually get involved, come to your facility. Any of you who've worked with them know how unbelievably professional and good they are, and help determine, hey, what are the strengths in terms of the practices of an IP in terms of preventing transmission? But where might there be some improvement in terms of, because it is absolutely key to make sure that hand hygiene and other IP practices are really at the top of their game to try and prevent the transmission of these highly resistant organisms from one patient to another. So what are some of the future directions that we are talking about? As I mentioned, we are going to continue. We now have regional antibiograms for about 3 large health districts and regions that we're working on, and we're going to continue to develop those over the next 6 to 9 months. We are going to probably also talk about, do we want to screen for CREs upon admission from folks who get transferred from places that are at higher risk? So people who get health care outside the United States are at very high risk for obtaining CRE or Candida auris, who transfer in particular from long-term care at certain metropolitan facilities that have high risk, like Chicago and New York. We always think what we find in Chicago, we're going to find here. And then there might be some times when there are certain facilities, even within the state, that have had some recent issues. Do we want to do some interfacility issues? But one last thing that I actually really want to focus on. In the process, as I said, the ball game had totally changed within the past 2 months in terms of the number of CREs. We have patients now. It used to be that all the patients were so ill that they might have gone from one facility to another, but they never came back for same-day procedures. They were never going in and out of rehab. And so the concept, we've had 3 scenarios where someone with a highly resistant CPCRE has gone from one facility to another, and the receiving facility, actually now 4, either for a same day or for transmission, and information about that person's resistance status was not communicated to the receiving facility. That is absolutely crucial, that information goes. And I think part of the problem, we're all so busy working, taking care of patients within our facility, a lot of times when they go somewhere else, it's kind of, there's, okay, all right, now I've got to turn back into my patients here, and there's sort of a sense of not as being responsible. Again, it's not intentional, it's just kind of the way the system works, but it is absolutely crucial that this information be imparted to receiving facilities, whether it's for one-day procedure or it's for a longer-term stay. And we have a simplified interfacility transfer form on our website, and it's attached and right near where you can find the other guidelines. So with that, I'll stop, and thank you so much for your attention, and I'm hoping that next year when we give the talk, we can say the numbers are down. But just also call us anytime you have a concern about a resistant organism, you think that someone's showing up and you want to know advice on how to contain it. That's what we're here for. So thank you.